Hello, dear colleagues. My name is Dmitry Druzhinin. I am a neurologist, neurophysiologist. Today we will talk about the possibility of combining electroneuromyography and ultrasound study of nerves and muscles, which was optimized within one software by Neurosoft company. Modern realities imply that electroneuromyography methods should be complemented by neuroimaging methods. Ultrasound and EMG methods are fundamentally two different methods of obtaining information. If ultrasound obtains information by constructing an image from the reflected ultrasound wave from human tissue, electroneuromyography is the analysis of electrical activity of muscles. Therefore, you can combine these data and get a bigger, more complete picture of muscle tissue structure in clinical practice. In the past, when we used only neurophysiology techniques, we correlated with the clinical picture, and it gave us a lot of information that we could relate to a particular nosological situation. Now we have the neuroimaging techniques, and there are the EMG techniques that can also bring us closer to a more accurate diagnosis or differentiate different discrete forms among themselves. So let's look at some of the points of interaction between ultrasound imaging and electromyography that we can use in our routine practice. Ultrasound muscle testing allows us to determine whether there is a mosaic of muscle damage or a diffuse change in all muscle groups. For this purpose, we can scan the areas of our body where the muscles are located in layers. I'm talking about the forearm muscles, the calf muscles. Here the muscles are in certain groups. For example, the leg muscles are located at the surface, and the flounder muscle is located deeper. Ultrasonic imaging allows these two layers to be differentiated precisely because the divergent location of the beams allows for better reflection of the ultrasound waves and defines this boundary. What does that give us? Firstly, it allows us to select the target muscle for EMG study that will be most changed, and it allows us to navigate the needle electrode to the part of the muscle that has the greatest changes in the ultrasound picture. Thus, we increase the accuracy of EMG of exactly that part of the affected muscle, which will be the most involved. Note that here we are oriented not only on the clinic, but also on the sonographic structure. Mosaic muscle lesions imply that some muscle fibers are preserved and others are altered. The most clear nosoology that demonstrates this pattern of change distribution is inclusion body myositis, IBM. The deep flexor of the fingers is mainly affected, but the superficial flexor of the fingers remains. It's quite good and accurate to see with ultrasound imaging. When the surface of the finger's flexor has a hypoethogenic structure, the deep one has a vivid hyperethogenic structure. Accordingly, the needle-like electromyography is most appropriate to be performed on the affected muscles of the deep flexor fingers. However, when we use the blind method, we cannot guarantee that the needle electrode is in a deep bend by having a surface bend to fill a certain volume. The needle electrode can remove the potentials of the preserved muscle. Here, the combination of ultrasound and EMG techniques allows us to achieve maximum accuracy. The second point of interaction of these methods is a paralyzed muscle, for example after nerve damage or neuromuscular pathologies of late stage that already leads to muscle paralysis. It is very important for us to understand whether this muscle is electrophysiologically preserved, whether there is some involuntary muscle movement here, whether there is recruitment of the potentials of motor units. As you know, when we use a needle electrode, we use the blind approach. We stick the electrode into a standard moving point and hope that this point will be recruited. But it does not always succeed. Sometimes the muscle is restored by islets where involuntary muscle movement appears. We may be near this island and not get a signal from this island. So when we use ultrasound imaging, we can find that particular spot of islet muscle contraction and figure out that particular spot has a visually defined muscle movement, and then navigate the needle electrode to this spot. In clinical practice, this gives a very large increase in the accuracy of the first signs of reinnervation after injury. When we wait for the first involuntary movement of preferential reinnervation, we will find the areas of muscle activity and try to record this potential from that area of the muscle. This will increase the accuracy of the EMG in terms of identifying the first signs of reinnervation by several tens%. This gives us a more accurate picture of recovery from trauma. The second point is that the muscle is recovered unevenly. Islets of muscle contraction can be removed and are disjoint from each other. Unfortunately, this leads to the muscle not being synchronously contracted. It also results in that there is no phase recovery of muscle contraction, despite the fact that electrophysiologically in this muscle, there is involuntary muscle movement in the form of recruitment of motor units potential. Ultrasound allows us to assess the synchrony of muscle contraction and thus predict how likely the muscle will recover phase contraction. In other words, this means how much these islets of muscle contraction will be synchronized and give already visually defined muscular movements in the extremities. This is very important in terms of rehabilitation and the need to justify a repeated reconstructive surgery on nerves. If, for example, after a long period of time there is electrophysiologically involuntary muscle movement, and clinically we do not see any muscle contraction, the ultrasound can estimate how much area of muscle contraction is, how synchronous these contractions are, and how likely is the outcome of movement recovery. This is so that the patient's arm contracts and reaches a muscular strength of 1 to 3 on the MRC scale. The next possibility of using EMG and ultrasound is to evaluate spontaneous activity, namely the potential for fasciculation. The potential for fasciculation is an electrophysiological term that has its characteristics according to EMG results: duration, amplitude, number of rounds, frequency with which these fasciculation are generated. But the needle electrode has a limitation. It only picks up signals from a very small area of the muscle. As we know, the potential for fasciculation occurs in different areas of the muscles, and it is absolutely random and unpredictable. In other words, if we get a needle electrode and we don't register the fasciculation, we can't guarantee that they're not exactly there, because they can be generated in neighboring muscle regions, and we just haven't registered them. Ultrasound allows us to visualize more muscle area and therefore allows us to be more sensitive in assessing the potential for fasciculation. However, we understand that by ultrasound imaging, we are not evaluating the fasciculation itself, but some activity of a group of muscle fibers, which is most often comparable with neurophysiological potentials of fasciculation. But we use another term for this: involuntary muscle movement. It has two characteristics. It can be stereotypical and non-stereotypical. Stereotypical muscle activity is when the same area of muscles with a certain degree of rhythm is reduced. We know that myopia is just a stereotypical involuntary muscle contraction, which will be characterized by an ultrasound visualization of a group of muscles that will contract with a certain frequency. Another characteristic is non-stereotypical muscle contraction. That is when we have the contraction of absolutely arbitrary muscle groups that will be contracted at different intervals in time, and this will be well visible by the results of ultrasound imaging. In order to capture these fasciculation potentials more accurately, especially if they are low amplitude, we need to reduce the smoothing effect on our ultrasound scanner and turn off all possible filters. Unfortunately, it happens that the filters absorb some involuntary spontaneous activity, smooth them out, and it becomes invisible to the human eye. So before beginning to register the potentials of fasciculation, we need to turn off this function. The next important technical point is no pressure on the muscle. If we are to press the sensor on the muscle, accordingly we can simply not register and not visualize these potentials of fasciculation, so it uses gel cushion effect when we place the sensor on a small thin layer and do not put pressure on the tissue. The literature is actively discussing the possibility of visualizing motor units. It is a new technique that is now developing more and more and has its application in the diagnosis of neuromuscular diseases, as well as in rehabilitation to restore muscle function after any nerve damage. This is a visualization of the motor unit. So far, the most studied is the anterior musculature of the testicle. The essence of the technique is that we give rhythmic stimulation by current to the fibular nerve, achieve a minimum current force that causes involuntary muscular movement of one group of muscle fibers. Usually this minimum current force is 5 to 10 milliamps. We visualize a section of this involuntary muscle movement, use a needle electrode and record the potential of the motor unit of that point. Then, using the energy Doppler mapping function or tissue harmonics, we can map this involuntary muscle movement from the ultrasound and give it a neurophysiological characteristic. This gives us not only the ability to objectify the area of the motor unit, but also to determine its shape. Researchers are currently collecting data that would allow the association of this indicator with a particular neuromuscular disease. The forms of the driving units are ellipsoidal, spider-like, round, oval, and so on. the shape of the motor units changes with the current, for example, of a neuronal process, or it can change with, for example, nerve damage during re-innervation. Unfortunately, we can't use this technique for any muscle as long as the data is being accumulated for the anterior tibia muscle, because it's a very convenient visualization of the motor unit in the lower segment of that muscle, close to the tibia, and there it is very reproducible. The methodology can be repeated several times and can be investigated in a dynamic way, as evidenced by a number of observations of the authors who published this work. Accordingly, behind this method, I think, there are enough prospects that will allow us to understand even more deeply the neurophysiological features of neuromuscular diseases. The next point of sharing EMG and ultrasound is the possibility to evaluate the architecture of muscular contraction. If we attach standard electrodes with variable interelectrode distance to the corresponding muscle and also put a sensor on that muscle, we can register the architecture of the morphological dynamics of the muscle from the results of the ultrasound and combine it with the electrophysiological interference pattern. This gives us a deeper and more precise understanding of the architecture of muscle contraction in the recovery process after injury. This allows us to estimate the strength of phase contraction and the inclusion rate of muscle fibers at maximum muscle activity. This gives us the ability to correlate neurophysiological parameters, amplitude, frequency, interference, curve characteristics with the rate of increase in muscle strength. This is especially relevant for athletes, people who are very important to get the maximum opportunities for a particular muscle. And this gives us the opportunity to more in-depth evaluation of the hemodynamic features of the muscle. We always forget that muscles are a blood-draining organ. Unfortunately, there is a chronic vascular diseases of the tissues. Microfibrosis can occur, and muscle may not provide complete phase reduction due to intraguiccianea fibromyalgia. We can also evaluate the dependence of neurophysiological parameters on the development of contractures. This is especially relevant in the context of Folkman. Ischemic contracture of forearms, which unfortunately now has a lot in routine clinical practice, not only neurologists, but also orthopedic trauma doctors. In the ischemic contracture of Folkman, intramuscular fibrosis develops in the muscles, which limits muscle contraction on this site, and accordingly changes the architecture, changes the synchrony of muscle contraction, which affects muscle strength. Accordingly, neurophysiologically, we will see a sharp drop in amplitude characteristics precisely in the areas of fibrosis. In those areas where the muscle is preserved, amplitude characteristics should be approximated to normal. Assessing the areas that are most affected is a pressing task for trauma, orthopedic, and neurosurgery doctors, who may use surgical methods to recover, such as fasciotomy or possible excision of necrotized mycelium. We cannot fail to mention the different muscle formations, such as muscle tumors, sarcomas, neurofibromes, which most often give a neurophysiological latent paresis, that is when the neurophysiological methods do not see the restructuring of muscles, but the function of muscles decreased. This dissociation always puts a neurophysiologist in a stupor. We apparently reduced muscle strength, but neurophysiologically do not define any alterations in the muscle. Muscle visualization will allow multiple, for example, myosarcoma in the muscle, which may not be visually defined by the appearance, such as in the surface change of the body covering, but can strongly affect the muscular force. No doubt, ultrasound will explain and help to distinguish these situations. In addition to muscle tissue, we can visualize nerves. There is now a large amount of research on tunneling neuropathy, where ultrasound imaging allows to visualize the medial nerve in the area of the carpal canal, the locotia in the area of the cubital canal, the shoulder pleura, the fibula, and other nerves determine the change in the area of the transverse section of the nerve, and this information will certainly complement the neurophysiological picture. You know that sometimes the neurophysiological diagnosis of carpal tunnel syndrome is limited. For example, we cannot get a motor response because of the atrophy. The neurophysiologist often asks whether it is tunnel syndrome or maybe some other pathology higher or lower. This question is often not possible to answer. The ultrasound in this case can localize the process and objectify that axonal process only on carpal canal is so pronounced that it simply does not allow us to determine the neurophysiological criteria of tunneling neuropathy, for example, carpal canal. Another example of a simple cross-stitch. Neurophysiology does not give us an objective picture of the injury of the pleura, and also the compression of the lower trunk at the level of the clavicular space. The most typical change will be the denervation in the chest muscle and the tendon in the elbow flexor. However, these changes are not specific. Ultrasound imaging of the lower trunk allows to clarify a possible pattern as an upper opening syndrome, such as possible increase in C7 transverse process, or, for example, additional cervical rib, or additional lesion muscle, or vasocerebral conflict. That is to say, to establish the cause of the syndrome of the top aperture. As you understand, the combined application of these two techniques already gives a complete picture and a full description of the situation that has arisen in the patient. In order to connect the EMG device and the ultrasound system, regardless of its class and manufacturer, we use a video capture board. Video capture board allows you to get streaming video from any ultrasound scanner through standard HDMI cable. I connect it to the EMG device, and then, through video capture, I connect it to the computer. Why is this the best solution? Because the manufacturer of ultrasound systems is quite different. There are portable devices of low quality, there are expert systems. To unify the work with any machine, it is sufficient to use just streaming video, and not to use directly combine as a single system of ultrasound and EMG. So the company Neurosoft has made it a focus on video capture and streaming. How that works, I'll show you later. In order to enable the video stream window directly in the software, we need to select a sample first. In this case, I choose the test common finger flex, left interference pattern. And then I go to the section View and press the button Video Window. There is a video stream from the ultrasound system. It is located on the right corner of the screen. Next, I'm inserting a needle electrode, and I'll try to show you a more typical muscle. This is the radial extensor of the wrist. First, I'm visualizing the muscle itself. Here it is in this shape. Under it are the return arteries, as well as the posterior intervertebral nerve. Try to unbend the hand now. You see the muscles contracting. In this case, I'm standing strictly above the beam relaxer. Then, using a needle electrode, I study this muscle and place the needle electrode directly in the middle of the muscle abdomen. This is the short head of a flexible brush. To be sure that I have the electrode here, you can move the needle, so it will be more clear where it is. Here's the tip of the needle. See, I'm manipulating it now. Then we turn on the signal recording, turn on the monitor and unbend the hand. Relax. Again, delay the folding of the hand. So I record the interference pattern from this point. I'm doing a full amplitude analysis on the right side of the screen and recruiting the MUP at this point. Let's loosen the hand. Next, I move the needle electrode to another part of the muscle and slowly reduce again. You can see that our architecture of muscle contraction is not the same as the interference curve. The interference pattern starts with some delay. First, there is a change in muscle volume and area, and then an information curve begins to be recorded. Here we see the recruitment of MUP. There are both high threshold and low threshold potentials. Let's relax the hand. We see the potential of injections. We see how the architecture of muscle contraction is changing. In this example, a person with a healthy muscle. So we see here the overall reduction of muscle fibers. That's the potential of now using needles. I lift it up a little bit and want to explore this area of the muscles. I'm recording patterns from this area of the muscle. Let's relax hand. Next, I'll go deeper. Here is my needle electrode, and I want to explore this area of the muscle. You see that these are more correct potentials. We are close to the point of propulsion. We see more correct potentials. Note that the moving point coincides with the most dynamic architecture of muscle contraction, which is very important for us. Let's relax the hand. I can then accordingly provide the navigation of the needle electrode to any other part of the muscle. Now you can see that I am lifting the needle electrode, and let me take it a little bit into another part of the muscle. One more time we are contracting the muscle. You can see that here we have moved away from the motor point a little bit. So there is more polyphase motor unit potentials. The recruitment is already different at this point of the muscle. Please note that the closer we get to this point, the more correct potentials we will register. Relax your hand, please. We see the potential of a needle. Here I will again look for a needle electrode. Again, we also contract muscle. I also got closer to a richer pattern. And it matches my more dynamic architecture of muscle contraction. So we've recorded interference patterns from multiple muscle segments, and we can analyze the potentials in these motor unit segments, and then collect already quantified potentials of motor units in different segments, and do statistical analysis. For imaging peripheral nerves, we will use standard ultrasonic access. For example, we now have the task of exploring the cubital channel area. Just in case, I will start scanning the Guyon's channel area to exclude possible compression at this level. The region of the hawthorn bone and the canal of the allograft are located next to the elbow artery. I then move on to the cubital canal. Here I see the ulnar nerve, which is adjacent to the medial supraspinatus of the humerus. Accordingly, using ultrasound system, I can make a corresponding measurement of the cross-section area of the nerves and save this image in the archive. Here I will write a comment that this is the ulna of the right nerve, and then this image will go into the appropriate protocol. This is very convenient because it allows us to save not only electromyographic data, but also image data during ultrasound examination. Next, I will create a protocol. Please note that I will have the ultrasonic images along with my comments saved during the study in the protocol. We see that the protocol we have includes data from electroneuromyography and data from ultrasound images. They are stored in the archive, and when I need to pick up a patient card, I will have access to the ultrasound of the ulnar nerve and its neurophysiological interpretation. We have demonstrated to you the possibilities of joint use of ultrasound and EMG within the framework of software Neurosoft, using Lightbox EMG machine and ultrasound system. Thank you for your attention.